Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational symposium titled Accelerating the Pace Toward the End of the HIV Epidemic. During this podcast, Dr. Nagalingeswaran Kumarasamy, Chief and Director at the VHS Infectious Diseases Medical Center and Director of Chennai Antiviral Research and Treatment Clinical Research Site at Voluntary Health Services in Chennai, India, discusses care pathways and linkages to care after HIV testing. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Kumarasamy has to say about HIV care linkages.
As we all know that in HIV care continuum, the crucial step to HIV any care continuum is linkage to care. As you see this from screening to diagnosis to linkage care, it's very important as we all know that from science. So when you link someone to care, it improves the survival and quality of life. And of course, it prevents the forward transmission of HIV. Here, CDC has a definition of a linkage to care that is more than one HIV RNA or CD4 cell count within 30 days of diagnosis is for the developed world. And we may have a different one for lower and middle income country. So this data just released last night by the UNH, and thanks to WHO, we got this data. So the worldwide HIV care continuum at the end of 2021, it's been 85% of the people with HIV already been diagnosed. Among the people with HIV, 75% receiving antiretroviral treatment and 68% virological suppression. Still a lot to be done worldwide. Let us look at this data from the United States by the end of 2019. With the people with HIV, 87 being diagnosed and 81% linked to care within 1 month. But again, the benchmark being 95%, even in the resource-rich settings like the United States. Among the people with HIV, 66% receiving care and 50% in retained in care and 57% virological suppression. Still a lot to do, even in the most resource-rich settings. As we all know that, based on the, various surveys and meta-analysis, structural barriers and ethnicity is a huge risk and barriers for linkage to, any HIV care continuum. And along with that, substance use, mental health, poverty, fear of stigma, and fear of medication adverse events. All these have been studied and been correlates for, poor linkage to care. So any program, what we have been planning, should have all these factors should become in place as part of a supportive care. In coming to the adherence, again, all these factors play a major role, particularly in adolescents, and as well as there is a belief that ART has cured HIV, or belief that GARD or ART has cured, and treatment fatigue. All these factors have played a critical role in poor adherence. And when we have been planning any program, I think all these factors should be studied and appropriately integrated in any care continuum model as a supportive care. So coming to the organized strategies to improve linkage to care for persons with HIV. So this is a recommendation from the International Association of Providers of AIDS Care, which clearly recommend the immediate referral to HIV care following an HIV diagnosis and use of case managers and patient navigators, and also to do proactive engagement and re-engagement of patients who miss chronic appointments and or lost to follow-up, including intensive outreach for those not engaged care within 1 month of new diagnosis. It's something, a recommendation from IPAC, which is again is very critical in programs for linking to care. A word about this the CDC-supported ARTA study. That's an antiretroviral treatment and access to service project for people who are not aware of it. So this is a program for linking newly diagnosed people with HIV into medical care. The ARTA's model used a case-based management and which was studied in 10 community-based settings and health departments of more than 600 odd individuals, where they individualized multi-session time-limited intervention designed to link individuals who have been recently diagnosed with HIV to medical care, with a primary endpoint of attendance of more than one medical visit within 6 months of enrollment. So just for one time and going into the details of the study, what's been found in that study is if they have a co-located HIV medical care, they got a higher factors which has been associated in attending more than one medical visits, and also with 2 to 5 sessions versus less than one session, which was been statistically significant. Now I'm going to have a quick faculty discussion. Might be just quick 30-second answers. First, start with Chloe. So data from this ARTA study is from the United States. Can you tell us in your country about this chance of this co-located care and the possibilities in your settings?
Yeah, it's a bit of a sad story because HIV was always integrated care in the UK, and we provided everything, all the drugs for all their conditions, HIV, hypertension, everything we prescribed. And over the last few years, we've no longer able to do that. And we're only allowed to prescribe antiretrovirals, and we have to refer people back to their primary care for all the other conditions.
Thank you.
So things have gone backwards in the UK is the answer.
Okay, so you have the best model.
Yeah.
Linda, what about in South Africa and your neighboring countries of Sub-Saharan Africa?
Yeah, so Kumar, we decentralized, and so antiretroviral therapy is largely at primary healthcare level, and has been a very vertical program. So actually, unlike Chloe, we started very vertical. We're now becoming aware that non-communicable diseases is our next epidemic. And of course, in younger people, sexual reproductive health services are absolutely key and critical. So we're starting to think how we provide differentiated service delivery now, but we still have a long way to go.
Yep. So I think it's very clear, from this study, and I think co-located care is a way to go forward. I think it's time in lower and middle income countries, we should look forward how we integrate as a supportive care for people with HIV along with the ART care. So intervention that may improve linkage to care for persons with HIV. So this is a very busy slide, again, based on from different studies and meta-analysis. It's particularly, from studies in the United States. Intensive outreach, based on this type of intervention, at 6 months, 92% attended, medical appointments. And HIV partner services, which is, again, very important, not only in the research settings as well as in developing countries. And shortened clinic appointments. This is a very nice program done in UAB, where they've shown the no-share rate decrease from 31% to 19%. So this is very, very important for our patients, to get linked to care and for sustainability of the care. Intensive case management. Again, the systemic review very clearly showed increased linkage rates, from, several studies. And again, same-day ART initiation can reduce time to clinic intake and viral suppression. All of you in this know about these two landmark studies. One is FRCP, which is a treatment as prevention, which has led to enormous public health benefit in starting antiretroviral treatment very early. And START study, which we all know that had prevented not only opportunistic infection, but also non-communicable diseases, and an enormous individual benefit. And the outcome of these studies transformed every treatment guideline, either in the developed world or developing guidelines to start treatment for everybody. So following this, the WHO made this recommendation on what is called the rapid ART initiation. That is, people who come with any symptoms, rule out opportunistic infections, or put them on medications, start an antiretroviral drug within 7 days, except in cryptococcal meningitis or any CNS manifestations. For someone who has been totally asymptomatic, diagnosed positive, and been counseled, and they're prepared to take ART, do that on the same day. And these recommendations are made based on previous studies, which very clearly shows that for someone who's not ill, if you're delaying treatment, you're not going to get them into the care. They may come and show up to your emergency clinic or to your intensive care unit after a few years. So these two key recommendations are now getting implemented, across the globe. The successful interventions to improve linkages to care in Sub-Saharan Africa. This is again from a very large systematic literature survey from 7 different studies of more than 24,000 participants, and very clearly showed rapid ART initiation improved linkages to care at 3 months after diagnosis. The study from Lesotho. And in Kenya, assisted partner services, very clearly showed 15% of those who received these partner services versus 3% of those who did not, been enrolled in care. And using healthcare workers versus lay providers is very important, again, as intervention facilitators, improved care linkages in 4 out of the 6 studies, and also a particular intervention site may also play a very important role in linkages to care. Now let us hear from our friend Lillian, who's a storyteller.
When we talk about health facilities, that it is not enough that we have healthcare providers there, but there has to be a whole section, for example, of counselors who are going to go out and support people. Because as a nurse, for example, even now, so many years back, you see that she did probably what she was asked to do, and maybe she was doing it with good intentions, but she did not know how that was going to impact on me. But probably if the hospital had a whole department that was dealing with counseling, and maybe they would have now said, okay, let's take you now to maybe first be counseled so that you understand the results that you're going to get and what it means.
So, the take-home points, from my presentation is that linkage to care after HIV diagnosis is critical for the prevention of forward transmission and to improve survival and quality of life based on clinical trials and as well as from ecological data. They need structures that facilitate co-located medical and HIV care, use of patient navigators and transportation services. And also is very important to continually engage and re-engage patients in their care for the better linkage after diagnosis to get the fruit in the HIV continuum of care.
Thank you very much to Dr. Kumarasamy and to our panelists, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and also the full Accelerating the Pace Toward the End of the HIV Epidemic program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.